Can you hear me? Can you see
Yes,
my screen?
yes, of course we
Perfect.
can.
So, good morning and good afternoon or good evening, wherever you are in over the globe. And my name is Ali Youssef. I'm a consultant of obstetrics and prenatal medicine in the University of Bologna. It's a pleasure to be here today to talk about ultrasound and labor with um, such a mm, huge audience. So let us start my lecture, and I will talk about the technique. So how to do ultrasound in the labor ward. The time is, of course, is a little bit limited. So we have published these ISUOG practice guidelines with Tullio as a first author and leading author of the guidelines of 2018. And you can refer to them for further details. But my job today will be to summarize the use of ultrasound in the world. So millions of years of evolution has led to this complex, unique labor in humans. So the rotational human birth, with the cardinal movements of fetal head descent, rotation, flexion, okay, during labor to reach and to dodge and to manage the relationship, the complex relationship between the fetal head and the maternal pelvis. And with ultrasound, we are able to objectively and accurately evaluate all these cardinal movements. So how to do it? Well, how to do ultrasound depends on what is your objective, but definitely what is essential is to have a systematic approach. So why do we do it? We do it to assess the fetal head malpositions and malpresentation, and to assess the intrapartum fetal head engagement. We have to always start systematically by transabdominal approach to assess the fetal occiput position and the fetal head flexion, and then go to the transperineal approach to assess the fetal head engagement and rotation and help assist us to evaluate the malposition and malpresentations. So these are the three views that we have to start with: transabdominally, on the transverse view under the maternal umbilicus. Then we go down to the suprapubic area. Then we rotate in a clockwise manner to have the sagittal view. And this is in a case of an occiput anterior, how we see the spine. And this is, we have anterior spine. Then we go down to look for the fetal head following the fetal spine. On the suprapubic area, we cannot see the orbits. Then we rotate by a clockwise manner, and we see the fetal occiput and the fetal cervical spine. So this is a case of occiput anterior. By following the same steps, we, in the case of spine posterior and occiput posterior, we see the spine posteriorly go down on the suprapubic region, and the hallmark of an occiput posterior is when we see the fetal orbits under the transducer. So this is definitely means that the fetal face is the fetus is facing the transducer, so the occiput is posterior. We can use the intracranial structures to help us to understand where is the occiput. So we know that the thalami is an umbrella-shaped structure pointed to the occiput, and the fetal cerebellum lies where the fetal occiput is. So this is the transabdominal approach, and then we go on the transperineal approach. There are mainly two views on the transperineal scan: the mid-sagittal view, or the sagittal view, and the axial view. And this is how we orientate the probe. The upper part of the transducer should correspond to the left part of our screen, and then we place the transducer between the on the perineum, on the labia, between the labia, and this is what we see. Centrally, the symphysis pubis and the fetal skull in the mid-sagittal view. So here we can see we can assess the relationship between the symphysis pubis and the fetal skull. It is important when we assess the mid-sagittal view to differentiate between what is the exactly median view and the parasagittal view. So in the parasagittal view, we are on the pubic bone. Okay, we see a shadowing behind the bone. Okay, and then whereas on the mid-sagittal view, we can see the cartilage of the symphysis pubis with no shadowing below it. We have to note that the vast majority of the literature produced on the midline parameter, on the sagittal parameter, are produced on the mid-sagittal view. So this is the mid-sagittal view, whereas if we are parasagittally, we see the bone. So this is not where we should measure most of our parameters. And we have to trace and be able to visualize and to trace the long axis of the symphysis pubis. So this is a line that divides the symphysis pubis almost in two halves and arrives not only to the central part of the cartilage, but the whole length of the symphysis pubis. By knowing this landmark, we can measure the angle of progression. So the angle of progression is an angle between two lines, one line passing through the long axis of the symphysis pubis, and the second line is starting in the lowermost part of the symphysis pubis and tangential to the fetal skull. So the nearer the fetal head to the transducer, which is up in our screen, the larger will be the angle of progression. So the wider the angle of progression, the more engaged the fetal head in the maternal pelvic canal. Then we can do scan on the axial view by rotating in a counterclockwise 90 degrees our transducer. And this is the image of the axial view of the intransperineal ultrasound. So we can measure two important parameters on this view by gently pushing on the maternal labia. We can measure the distance between the symphysis, the transducer, and the fetal skull, what is called the head perineal distance. Okay, and the other parameter, which is the only parameter with which we can transperineally examine the fetal head rotation, is the midline angle. So the midline angle, we know that the lower the fetal head in the birth canal rotates usually in the anteroposterior axis of the maternal pelvis. So especially in an occiput anterior position, the narrower the midline angle, the lower is the fetal head in the birth canal. So this is how we measure it. Between the midline angle is an angle between two lines. The first one is the midline of the fetal brain, and the second one is the anteroposterior axis of the maternal birth canal. So the narrower the midline angle, the lower is the fetal head in the birth canal, and the better is the outcome. Lastly, we can measure the flexion and deflection of the fetal head in the sagittal view. So this is an occiput anterior with a wide occiput spine angle. So the fetal head is definitely well flexed on the fetal chest. Whereas these are two deflexed fetal heads in a face and a brow presentation. And this is the case of a spine posterior. So the fetal is facing up, and we can see how the fetal spine is very deflexed in the axial view. So by this slide, I finished the technical part of the synthesis of the ultrasound in labor technique, and I pass the word to Professor Tulyugi to talk to you about the clinical utility. So when to use it, please feel free to write us any questions. If you have any question, we'd be delighted to answer them. To you, Tulio. You're muted. Tulio, you're muted.
Yes, can you see my screen now?
Yes, we can.
Okay, so good morning or afternoon, wherever you are. I'm going to cover now the main clinical application of intrapartum ultrasound. Actually, I will start with the usefulness of intrapartum ultrasound in improving the prediction of cesarean delivery in women with prolonged first stage of labor. This is one of the first studies that have demonstrated how useful is intrapartum ultrasound in this setting. This is a study that comes from Norway, the group of Professor Egebo, together with a group of Christoph Lees from London. They have assessed a group of nullips with a prolonged first stage of labor. They have done the clinical evaluation, clinical assessment, and they have measured transperineally the two parameters that Ali has just shown to us, the angle of progression and the head perineum distance. And as you can see from the ROC curve, the two sonographic parameters were more accurate compared with the digital examination in predicting the need of cesarean delivery in these women who were apparently stuck in the first stage of labor. And when the two sonographic parameters were favorable, the angle of progression wider than 110 degrees and head perineum distance shorter than 4 centimeters, the residual chance of having a vaginal delivery was still very high. We have recently conducted a study on women on the prolonged first stage of labor, and we decided to assess, together with the station, also the attitude of the fetal head using the transabdominal ultrasound approach that Ali has just shown to you. We have measured the occiput spine angle in occiput anterior and occiput transverse fetuses in order to evaluate the flexion of the fetal head. And we have also tried to quantify the deflection of the fetal head for fetuses in occiput posterior position and measured what we have called the chin-chest angle. Interestingly, we have noticed that for fetuses that were occiput anterior or occiput transverse, when the women could have a vaginal delivery, the occiput spine angle, the angle of flexion, was significantly wider compared with the woman who needed a cesarean delivery. That means that the fetal head was more flexed. While when the fetus was occiput posterior position, the angle of the deflection, the chin-chest angle, was wider when the cesarean delivery was needed. So it means that, again, when the fetal head was deflected, the residual chance of having a vaginal delivery for women stuck in the first stage of labor was lower. And these are two cases, well-flexed fetal head and the flexed fetal head with the occiput anterior or occiput transverse position. So occiput spine angle was measured. These are two examples of flexed or deflexed fetal head in occiput posterior position. At multivariable logistic regression analysis for both type of fetal position, the angle of flexion of the fetal head, the occiput spine angle for occiput anterior, occiput transverse, and the chin-chest angle for occiput posterior position was among the significant predictor, independent predictor of the chance of vaginal delivery. So we know that the secondary arrest of dilatation is mostly due to poor fetal head descent, and malposition and malpresentation are the leading causes of lack of fetal head descent. Thanks to intrapartum ultrasound, we may identify both malposition and malpresentation. This may help the clinician in the management of such cases. The second good reason to add intrapartum ultrasound to the standard care is the fact that we can use ultrasound and improve our ability to decide between a cesarean delivery or instrumental vaginal delivery and predicting the chance of a failed instrumental vaginal delivery. This is a study coming from France where more than 230 women were about to be submitted to vacuum extraction. Just before that, the angle of progression was measured. In this cohort, there were 12% of failed vacuum delivery. There was a cohort of fetuses, including also malposition, so occiput posterior, occiput transverse position. Interestingly, as you can see from this slide, the clinical station was not significantly different between the failed and the successful vacuum extraction, while the angle of progression, that means the sonographic station, was significantly lower, more favorable for women who had a successful vacuum extraction. So that means that it's more useful, more reliable measuring the station with ultrasound than digitally to predict the failure or success of vacuum extraction. Similar study, in this case, were more than 650 women submitted to operative vaginal delivery, another study from France, Overall, 18% of these instrumental vaginal delivery were defined as difficult. The authors have measured not the angle of progression, but on the axial plane, they have measured the head perineum distance. And as you can see from this table, the head perineum distance that is in the study is called the PSUD, different acronym, was the most significant predictor of a difficult instrumental vaginal delivery, much more reliable than clinical station, as you can see from this rock curve. Very recently, this study was published yesterday. I've been part of this collaborative study together with a French group. We have assessed the head perineum distance in predicting the outcome of one of the most difficult vacuum instrumental vaginal delivery, the mid-cavity vacuum-assisted delivery. It's a very large study, maybe the largest published so far, with more than 900, almost 1,000 of women that were recruited for this study. They were submitted to mid-cavity vacuum-assisted delivery, and just before delivery, they were submitted to the measurement of head perineum distance. There was a failure rate in the range of 25%, which is not low, but it is just a study with vacuum. So this may explain this relatively high rate for anyway a difficult type of instrumental vaginal delivery. And as you can see, the head perineum distance, so the station measured at ultrasound, was among the significant predictor of the outcome of this mid-cavity vacuum-assisted delivery. So, and while the clinical station is not included among the predictors. And interestingly, if we compare the measurement of the station at ultrasound and the digital examination, the measurement by ultrasound was much more accurate. If you see the interquantile range of a measure of a fetal head engaged at clinical examination, there are a lot of measurements, 25%, that are definitely above the level of 0. That means that most of the time with the digital examination, we think that the fetal head is engaged, while in fact is not engaged. And you can see from these figures that thanks to the use of ultrasound, we can be much more accurate in deciding when it is the case to proceed with the mid-cavity vacuum extraction, while with the clinical assessment, the chance of failure is much higher. There are some groups that have proposed the use of intrapartum ultrasound during the procedure in order to guide, for example, the placement of the blades in case of the forceps, rotational forceps. This is a study coming from the Charité Hospital, a study from Wolfgang Errich and Larry Inkson. And very recently, we have tried to use the intrapartum ultrasound to guide the placement of this new device for instrumental vaginal delivery, or the Odon device. This is an IMPRESS study. You can see, I know that most of you now are familiar with this new type of instrumental vaginal delivery that maybe will spread in the next few years. It has just received, it is about to receive the CE mark. You see the spatula of the device just between the pubis and the parietal bone for the occiput anterior fetus. And for OP position, you can see that the spatula is just sleeping on the fetal face, on the orbits, and then resting on the lips and on the chin. So unfortunately, the only randomized control trial that has compared standard care to intrapartum ultrasound in assessing the outcome of instrumental vaginal delivery and the benefits for the mother and for the baby has not shown a significant benefit when the women were submitted to intrapartum ultrasound. But as you can see, the numbers are quite low, quite small, 222 women that were enrolled. So no demonstration of benefit for composite maternal neonatal morbidity, and no difference in terms of failed instrumental vaginal delivery. But with the 222 patients that were enrolled in the study, we could not demonstrate a benefit of ultrasound, because due to the fact that the incidence of failed instrumental vaginal delivery and the incidence of complication for the mother or for the baby, fortunately, is very low. To prove a difference, we need thousands of patients, and actually the study that have been published so far have not reached such a power. Due to this awareness, ISUOG guidelines that have been quoted by Dr. Youssef have endorsed the use of intrapart ultrasound for both indication dimensions, so women with a prolonged first stage of labor, but also second stage of labor, and women that are about to be submitted to instrumental vaginal delivery in order to decide to assess the fetal head position in the station to decide if the instrumental vaginal delivery is feasible or not. We are pleased from the fact that also clinical guidelines coming from the Royal College has recently endorsed the use of ultrasound before instrumental vaginal delivery to assess the fetal head position whenever uncertainty exists, while there are still some reluctance to include also the measurement of the fetal head station, although we think that this maybe will be one of the forthcoming steps. I want to finish inviting all the audience to be to attend or to be connected with this new event on the intrapart ultrasound, the Island meeting that is scheduled on an annual basis. This year will be in London, 31st of March, 1st of April. I want to thank you for your attention, and now I think that we can open our discussion. It is a pleasure to welcome Professor Rasha Kamel that we will chair this part of the discussion. Rasha.
Thank you, Tullio, and thank you, Ali, for the very interesting presentations. And thank you for the FMF and the ISUOG for this lovely opportunity to be with you all, with everybody, and to present this on behalf of them, to be with my friends and co-authors. We will start the discussion. I'm going to check for the questions. The first question we got was somebody asking how much hands-on training does one need to do intrapartum ultrasound?
Ali, you want to?
I think that it can be a collaborative answer, because I don't think that we really have a. I know that we like numbers, so we'd like to have a number, but I think that it's very hard to give a number. I think the only study that I've assessed it maybe has found at least 20 hands-on with an expert operator. So I think it has depends on many factors. Okay, but one critical point is to be trained by someone who is really who is an expert, who has experience, because it's very easy to get it wrong. As I concentrated on the for example on a simple parameter on how to trace the line of the symphysis pubis. Okay, because if you start doing it wrong, it can have quite disastrous consequences. And of course it depends on your background, and I would say also your age. So I from my experience, the younger the faster, okay, which is quite intuitive. And if you have background experience in ultrasound, so if you already know what is the intracranial structures, if you have experience in ultrasound, definitely have a faster curve. So it
regarding the assessment of fetal position, this is something quite easy to be achieved because we tend to use ultrasound for general obstetric evaluation. In this case, we need more or less transabdominal ultrasound. It's not that easy to recognize an OP position, OA position, or transverse. Maybe the assessment that can be a bit more tricky is the transperineal assessment of the fetal head station. And maybe we can say that the assessment of the head perineal distance apparently can be something easier. I remember that you have published a few years ago the results of a questionnaire that you had submitted to some attendants, and the people were more keen to use something to measure something without angles. Can you give us a short summary of that study that you published, Ali?
Yeah, well, the study that we published together many years ago, it was actually in the beginning of the era of ultrasound in labor, and we wanted to check in how the approach and and the perspective of the caregivers to ultrasound in labor. And actually, most of the obstetricians were found that measuring angles can be a little bit tricky, and that definitely the easiest for them and the most useful in the labor ward is the determination of the fetal occiput position. Okay, so yeah, probably having few simple parameters can be the most convenient one. Okay, but of course, we know that although the head perineal distance may be the easiest, okay, it does not have a landmark. Okay, so whereas in the mid-sagittal view, if you see the symphysis pubis, you have a landmark and you can assess the relationship between the symphysis pubis and the descent of the fetal head. So and fortunately, we have a lot of data of both of them. So I think it depends on your training. So if you are more confident with the head perineal distance, you can use the parameter for the head perineal distance in case you need a helpful opinion. For example, as Tulio showed us before, the application of a vacuum or a forceps. Okay, and if you are more confident with the angle of progression, I would go with the angle of progression. So it's we have a lot of literature of both the complex and the simpler parameters.
Well, actually, if you remember, Ali, you and I, we did some sort of a similar publication. You remember we had this course and we did a questionnaire for the attendees, whether they find it difficult or not to use intrapartum ultrasound and how they found the practicality of that. And then did the questionnaire after they finished, and we actually took the measurements they did at the beginning of the course and we compared it to the measurements that they did after the course. And as regards as the impact, they found, well, they changed their mind dramatically after the end of the course, and they said that what they believed to be extremely difficult, which is conducting intrapartum ultrasound, they found that it was actually easy and helpful. And as regards the accuracy, we measured the angle of progression and we compared the values, and we found out that the precision of their measurement of angle of progression was doubled at the end of the course, which means that the coefficient of variation has been halved. And that was very, very impressive just from a single course. So I think this also answers the question. I mean, I personally think it's an easy skill to acquire, relatively easy skill to acquire once you put yourself to it. And of course, you have to have the time to practice and to try to better your practice and try to improve. And of course, you have to have a good mentor to start your practice with or to start your learning curve with. And again, this would bring us to another point is for you, Tulio and Ali, how frequent do you think auditing images for ultrasound, intrapartum ultrasound practice would be good?
Yeah, this is a very important point because it depends on the indication. Of course, if we stick to the two main indications that I presented, when we are in the setting of deciding on how to deliver a baby, how to expedite delivery in the second stage, actually one single assessment can be enough. While when we are monitoring a woman with a prolonged first stage or second stage of labor, multiple serial measurement can be helpful in order to assess the longitudinal variation of such parameters. So in this case, I think that is extremely useful to assess serially. It can be something similar to what we do with clinical examination. Also, there are data, very interesting data from Israel that have been published this year, where they've shown that, especially when you are monitoring throughout labor the progress of women with rupture of membrane, the use of transperineal ultrasound can be even safer than multiple digital examination because it may maybe decrease the risk of infection, and also the perception of the woman of the transperineal ultrasound is something that is seen as less intrusive and maybe less discomfortable. So I think this is a matter that can be also, an aspect that can be also a matter of discussion. And just to summarize, yes, of course, multiple ultrasound assessment are needed and are definitely warranted when you are monitoring longitudinally the progress of woman, when you are suspecting that there is a slow progress of labor in either the first or the second stage of labor. Yeah. Do you think, I don't know who of you wants to answer, one of the questions that usually rises from the audience when we are proposing to implement the use of intrapartum ultrasound is the fear that we can lose our clinical skills, that using ultrasound we may become less good, less clever in assessing the position or the station. Rasha and Ali, what's your opinion on that?
Well, I think actually, personally, I don't agree with this concept because, well, for starters, we can actually use ultrasound to better our vaginal examination. For me, I always say ultrasound for me is very crucial. I always believe in seeing is believing term. So if I see something, this is much better than if I just sense it or I try to feel it. And I think it's a very important tool in educating the junior obstetricians or the junior doctors in the L&D, because you can actually demonstrate to them what they are trying to feel and what they are trying to conceptualize. So I think it's a very important tool in education to begin with, to actually improve the digital examination and the clinical assessment. I don't really see how it would affect negatively the clinical assessment. And when we're always giving lectures about the uses of ultrasound in labor, whether intrapartum, antepartum, or before induction of labor or whatever, we always say that it has to be taken into consideration, or it has to be viewed within the concept of the clinical scenario of the patient. So I don't really see how.
Yeah. There is a nice question from the audience. Maybe Ali, you want to get it? It's very important. Do we need to do all the parameters or just one?
Yeah, very interesting. Actually, I would like to comment on also on the point raised that you raised, that Russia responded, and I think it's very important to, well, from my point of view, I agree with what Russia said, and I think that like any instrument, it depends on how you use it. Okay, so ultrasound does not reduce your clinical skills. Your approach to ultrasound in labor can reduce your skills. So if you consider that ultrasound is a unique technique and you replace your skills or learning obstetrics with ultrasound, which is not recommended, it may be risky. But I think that if you use ultrasound appropriately, like Rasha said, you examine, okay? So it should not cancel or replace our skills. It can actually improve our skills. So I remember very well when I learned I learned obstetrics and the fetal position determination. Without ultrasound, it was subjective. And if we disagree, usually the one who is right is the oldest one in the room, okay? So now this cannot happen anymore. So if I say that in an occiput posterior and another say that in the occiput anterior, and we have the eyes facing the ultrasound probe, okay, one of us is certainly wrong, and we know who is wrong, and we can re-examine the patient and refine and improve our clinical skills. So I think this is how ultrasound should be applied, to refine our examination and our management, not to cancel our skills. The question that you're addressing is really important, and if you should use one parameter or many parameters. Okay, so definitely by transabdominal is necessary to examine the fetal occiput, and then to combine it or not, to use just one parameter or not, I think that we do not have an answer for that. I personally, before doing an instrumental delivery, in case of that I need help, so I'm not sure in that, like in many cases, on what is the best approach, I have to intervene, and I'm not sure whether it's better to do cesarean section or an instrumental delivery. I do the transabdominal ultrasound, and then I go for the angle of progression. Okay, I base mainly my decision on the angle of progression. Okay, so others use the head perineal distance, and others use a combination. I prefer to mainly have two main data, the fetal head position and the angle of progression. But I know that this is not the only approach, and this is where it's essential, this discussion. So I'm really keen and eager to hear your opinion.
I would like to add a short comment. I think that in general, you are right. We know that the more data we add, the higher is the source of error. This is a general concept in science. And of course, we ultrasound, that's a good guide. I think that one of the problem is that when we have the impression or when we have the awareness of fetal head malposition or malpresentation, I want to be more clear. With the occiput anterior position, I fully agree with you, the angle of progression can be enough, or the angle of progression or the head perineum distance. But for example, this has been discussed at one of the last webinar of ISUOG last week. When we have, for example, a persistent occiput posterior position, we can have discordant information coming from the angle of progression and the head perineum distance, because the pattern of descent of the fetal head in the birth canal is slightly different compared with the occiput anterior position. Then we can have, for example, an head perineum distance that apparently is favorable because the head seems quite low, but the orientation of the head in the birth canal is very posterior. It goes towards the concavity of the sacrum. Then we can have a relatively narrow angle of progression. And in that discordance on findings, maybe to have both information, the head perineum distance and the angle of progression, can be useful to take the right decision. But yes, in general, I agree with what you say. There are other 2 or 3 questions. One is regarding the cervical dilatation with transperineal ultrasound, and another question regarding the assessment of the estimated fetal weight and the type of probe for the transperineal assessment. Rasha, do you want to give an answer to these 3 questions, or maybe to one of the 3?
Well, let's take it by order. The first question about measuring the cervical dilatation with transperineal ultrasound. What is the technique? Well, the technique is basically the technique of transperineal ultrasound. Although in the cervical dilatation, you could actually use both application of probes, and I've tried it myself. You can try the vertical application of the probe, which is the longitudinal application of the probe to the perineum, where you will get very similar image to what we would get with the transvaginal scanning of the cervix, where we would get the whole of the cervical canal from external os to the internal os, and then you can actually measure the dilatation and together with the cervical length. Otherwise, you would transperineally, another way to do it is to apply the probe horizontally at the level of the cervix. And then if the cervix is dilated, it would appear like a circle or like a donut. And then you can just measure the transverse diameter, the widest transverse diameter, and this would give you the cervical dilatation. I don't know if Ali or Tulio has, they have different techniques for that, or did they do it at all?
No, actually is not one of the things where I see a real usefulness of ultrasound. There have been papers on that, but these papers actually were self-limiting. After a couple of papers,
it hasn't been proven of any clinical value. I agree.
So I'm really skeptical on the fact that this can be something really useful, because anyway, it can give you some information until a certain threshold of dilatation. After 6 to 7 centimeters, you don't see clearly the border, the edge of the cervix, so you cannot be so accurate in doing this measurement.
I agree, especially if you have a ruptured membranes.
Yes.
Second question is about determining the estimated fetal weight and gestational age in the second stage of labor, since many women in low resource settings come for scans pretty late. second stage of labor.
Can I say something? Regarding the estimated fetal weight, of course, we cannot date a pregnancy in the second stage of labor. Regarding the assessment of weight, this is something that in a particular setting, like for example, low-income country, I can understand the chance of obstructed labor for a woman that has not been assessed previously can be a matter that has a clinical relevance. We have recently proposed in these specific circumstances, rather than assessing the estimated fetal weight, the assessment of the fetal head circumference that seems to have a greater impact compared with the estimated fetal weight in determining the risk of obstructed labor and cesarean delivery due to cephalopelvic disproportion. And we have also proposed that this is something that so far there are just a few preliminary data that needs to be reassessed. We have proposed in these women to assess the combination of the head circumference at the onset of labor and the diameter and the obstetric conjugate that now with the new ultrasound machine can be more easily measured and assessed in order to predict the real risk of obstructed labor for a woman that has not been assessed before labor. This is something that, especially in the setting that is proposed, can be of crucial importance.
The subpubic arch angle as well, Tullio.
What?
And the subpubic angle. The subpubic
Yes,
arch angle.
the subpubic angle actually seems to be more important in determining the deep transverse arrest, but the big problem regarding the cephalopelvic disproportion is that the fetal head cannot enter the pelvic brim when it's too big for the entrance of the birth canal. And maybe the obstetric conjugate, in my view, can be more important than the subpubic arch angle that is relatively less. It can give us information. Maybe it seems useful, especially when you are predicting the chance of obstruction in the breech delivery. There are data regarding the subpubic arch angle in breech delivery, but regarding the incidence, the prediction of obstructed labor due to cephalopelvic disproportion, it seems that the obstetric conjugate is more important. So this is something that can be analyzed in extended series in the forthcoming years. Maybe regarding the type of probe, Ali, you have just shown on the video how to prepare the probe. You can say a few words on that.
Yeah. So so the action on the question on which transducer we use. Well, we use the regular convex transabdominal transducer, and a technical detail. It's best to have the wider angle. So in order to have the most appropriate visualization. Actually, I think that in this context we can even talk about in just 2 words on a new application, which I think that it may have especially some applicability in low-income countries and in countries where the breech delivery is scheduled and useful. So till now, all the images and all the application that we showed is on the fetal head. Okay, and there are some new data that the same angle of progression that we measure for the fetal head, we can measure reliably on the fetal breech. Okay, so of course, in many clinical realities, it's unthinkable to measure the engagement of the breech to plan for a breech delivery, but we know that in many other contexts it may be useful. So definitely having a slightly higher risk in comparison with cephalic presentations, I think that the applicability of the intrapartum ultrasound to have a safer breech delivery in clinical realities where breech delivery is planned, I think this can be extremely useful and promising. And I really encourage obstetrician working in labor wards where breech delivery is planned, okay, to use the ultrasound to learn and maybe teach us better on bridge delivery, which we unfortunately we in many clinical relatives we stopped learning about the topic.
There is an interesting question. I can take the privilege of giving an answer regarding the use of intrapartum ultrasound in predicting the shoulder dystocia. There are a couple of studies on that. One study coming from Hong Kong, from Professor Weilam Lau. They have assessed in women at high risk of shoulder dystocia due to gestational diabetes or diabetes in general, large for gestational age baby. After the head delivery, they have assessed transabdominally the fetal humerus, and when they could not see the fetal humerus transabdominally, that means that the fetal shoulder was started the engagement, so the shoulder delivery was quick and uneventful. In the few cases where they had a difficult shoulder delivery, they could image the whole length of the humerus transabdominal suprapubically. So this is a predictor, but not a predictor ante partum, a predictor just after the head delivery of the occurrence of shoulder delivery. We have done a similar study, but it was study of physiology, where we have imaged the orientation of the fetal head scapula compared with maternal pubis, and the orientation of the fetal head scapula correlates with the orientation of the bisacromial diameter in compare with the pelvic brim of the birth canal. What we have found with this study is that in the textbook, we have learned that usually the bisacromial diameters engage on the left oblique diameter of the pelvic brim, and this is what we are used to think about all deliveries, but this is not the case. Thanks to this study, that was a sort of proof of concept study that was conducted transabdominally, we have noticed that there is a 25% of normal delivery, shoulder delivery, where the bisacromial diameter engaged transversally on the pelvic brim of the birth canal. So the message is that maybe thanks to the use of intrapartum ultrasound, we may rebuild our knowledge, our concept regarding the obstetric semiology, because the textbooks have been, of course, produced with the theories and the concept that come from the clinical practice. But thanks to the eye, we can definitely refine and readjust some concepts. I think that we are almost at the end. I don't know if Rasha, Professor Kamel, do you want to give a few words to close the session, because we are really at the end of our time?
Yes, well, again, I would like to thank Tullio and Ali, my dear friends and co-authors, for a lovely presentation. Also, thank you for all the interesting questions that made the discussion very impactful and very clinically oriented. I hope you had all enough information and you've benefited from it. So we're going to go out for a short 20-minute break, and we will be back at 11 UK time for the next session, which is the fourth session about first trimester scan. It will be chaired by Professor Shawi from Germany, Professor Poon from Hong Kong, and Dr. Enabuduso from Nigeria. So please, just a short break and be back to tune in with us. Thank you very much.